So bonjour, hi, welcome, bienvenue to Montreal. Our first speaker will be Dr. Philippe Joubert. He's a friend of mine. We did our PhDs together actually a long time ago. But now he's a practicing pulmonary pathologist at l'UCPQ in Quebec City, Université de Laval. He's also a member of the ISLAC staging committee, so he'll be able to let us know a little bit more about the future, the history and the future of our TNM system. Thank you.
So thank you very much. It's a great honor and privilege to be here this morning, kick off this meeting. My name is Philippe Joubert. I'm a pulmonary pathologist. I also try to do some research. And as Pierre mentioned, I'm involved in the ISLC committee. I've been involved for the last 8 years. Thanks, Jonathan and Normand, for the invitation. Again, it's a great honor to be here this morning. So the idea today is to briefly touch on the history of ISLC and lung cancer staging project, but also to share some thoughts about what we've been through during the preparation of the 9th edition, but also how we see the future and the 10th edition of the TNM. As you know, we've already started working on that now a year ago. So I was speaking with Ramon Remy Porta a few years ago at World Lung, and he said, Philippe, if you're to get involved more actively in the ISLC staging committee, you really need to read this book and to know a bit more about all the history behind the ISLC project, staging project. And I recommend this book. There's a chapter on the history of the staging committee and the pathology committee as well, which is very, very nice summary of the staging project. But basically everything started a long time ago with Pierre Denoy, a French surgical oncology surgeon. We started to put in place the TNM, the first version of the TNM, which is basically about features of a tumor, lymph node metastasis, and also a distant metastasis. The lung cancer adopted by UICC, first real version of a staging TNM was proposed in 1966, and then the TNM was adopted by the AGCC in 1977. And it's interesting to know that the first 5 versions of the staging guidelines were based on the North American database of about 5,000 lung cancer patients, which was built basically by Dr. Montaigne from the MD Anderson. But although it was called the international staging, there was absence of international representation from different populations. So in 1996, during a workshop on intrathoracic tumor, Dr. Goldstra started to organize that. So we regroup a panel of international experts, and they basically agree on a few things, including agree on what would be the requirement of nodal assessment, try to come up and to harmonize the different definition of lymph node map, and also a definition of complete resection of lung cancer. But most importantly, I believe, is they agree to make periodic revision of the TNM, which would be based on a real international database that would include a population from all over the world. So the ISLC staging committee, as we know it today, was formed in 1998, and then CRAB, which is the statistical center, was integrated a few years later, and then started to work on the EDC, which is the electronic data capture that we use to collect cases. And they built that for the preparation of the 7th edition of the ISLC. And that gives a brief overview of the last 3 editions of the TNM. And I think here I wanted to emphasize that in the 9th edition, we started integrating or at least studying non-anatomical factor, which is the molecular data. We started collecting data with the idea of maybe see what would be the impact on the prognosis and clinical evolution of this patient. So this is a summary of the 9th edition, which was led by Dr. Isao Asamura, a surgeon from Japan. And that included 125,000 patients, so a lot of patients. Unfortunately, only 77,000 of these patients were usable for analysis because of poor quality or incompleteness of the data set. And of note, only 24,000 of these patients were actually collected through the EDC, which created some problem about harmonization and also reliability of the data. And basically, the collection spanned a period of 2011 to 2019. But for some of the batch data that were collected through National Registry of Cancer, some patients were actually collected early 2000. So you can imagine that it created some confusion and some problem when it got time to analyze this data. 78 institutions participated to that from 25 countries. A lot of patients were coming from Asia, and only 18% of the patients were coming from North America, and only 2% from the rest of the world, so Africa and South America. And this is my personal opinion, but you might agree or not, but it was felt that after the publication of the recent publication of the 9th edition, there was minimal changes, let's put it that way, in the staging system. So basically, adding some granularity to the metastasis and to lymph node, and also modifying a little bit the grouping of the stage. So that two questions arise from that. The first question is, how can we learn from the past to improve the quality and what we can extract from the anatomic information that we get from the database? And the second question is, have we reached the limit of the information that we can generate using anatomic database? So the 10th edition of the staging project is being led by Dr. Valérie Rouge, I'm sure that you all know from Memorial Sloan Kettering, and the co-chair is Raymond Osaro-Gabon from Memphis, who's also an oncologist, and Young Kim is the leader of the lung domain. So these three persons have been working over last year very hard to start organizing the 10th edition of the staging, and they've been working extremely efficiently. I have to say, I was involved in that, and I'm always impressed by the number of meetings and how things are progressing so quickly, although it's very complex, right? And we've learned a lot of important lessons from the 8th and the 9th edition, and let me share with you some of these lessons that I believe we've learned. First is we had a lot of poor quality data that represented a hurdle on when we get to the time of analysis. And some example of that is, just to give you example, is we ended up with adenocarcinoma in situ, minimally invasive adenocarcinoma, and then we looked at the pattern and we saw that this cancer had invasive pattern, and so there was nothing we could do for these cases. Multiple synchronous lesion was a big problem because of the definition of these synchronous lesions. So there was nothing at the end that we could do with that. And again, lymph node station definition was also a big problem. And I have to admit that not too long ago, when I was receiving a lobectomy in pathology, I was still calling the lymph node peribronchial lymph node, right, or peri-hilar lymph node, which is not very useful when you want to get more details about what exactly is the station that you guys are submitting in pathology, and where do we have metastasis and how many metastases that we get. Also, we ended up with outdated classification, so a lot of cases that we were receiving, or we were still using bronchoalveolar carcinoma. So what was the translation of that to lipidic and this new pattern that were described in 2011 and integrated in 2015 in WHO classification? There was no data quality monitoring along the process. So we ended up 2 years ready to make the analysis, and then realized that there was a big issue about data quality. There was no funding provided for the center participating and providing cases and entering cases in EDC, which is a very time-consuming task. So sometimes summer student would enter cases, sometimes a fellow, which is in general overwhelmed, resident and rotating resident. So there was no consistency across the process, which again created problems. So that was another challenge that we had. There was no objective upfront. So basically, what do we want to address in this edition? Which scientific question? What do we want to be able to demonstrate as it has or no impact on the prognosis? So that was a problem also that we realized, in addition to unbalanced representation of the population. So Dr. Rouge put in place some, I would say, priorities that we should try to emphasize for this next edition. And the first one, and we've been working in the last 6 months on that a lot, is generate objective. What do we want to address in this 10th edition? And try to evaluate how many cases, high quality cases, do we need to be able to address this question. Emphasize data quality instead of data quantity. Provide funding for centers that are sharing high quality data. Prioritize EDC data collection instead of batch data set to make sure that we can monitor the quality and also make sure that everything is the same format that what we are building in the EDC. Monitor data quality along the way in each participating center, making sure that the quality is there. And then favor prospective data instead of going back 5, 6, 7 years behind and being outdated in terms of classification. For some specific question, more detailed question, we felt that it might be interesting maybe just to work with specific center to make sure that the quality was there and was reliable in terms of analysis. There's also some reality checks that we need to keep in mind when we do a project like that. Staging project is not a research project. So basically, when we do a research project, we want to do fancy stuff. We want to try to build something, discover new things. In the staging project, there's not always room to do that because you want to use data that you can available across worldwide and not only in 1 or 2 centers. But at the same time, we have this unique opportunity to collect thousands of cases, and we could be able to use these cases to actually address very relevant questions. And the example of that is ctDNA. So people are using ctDNA right now to find resistant mutation or to find actionable mutation when we have a failed tissue biopsy. But ctDNA as a prognostic marker, there's not a lot of centers that are actually doing that. But we know that in 5 years, that might be something that will be extremely relevant for the staging. How can we deal with that? So basically, we've put the project in parallel, trying to start building some evidence, and when the time is right, then we can integrate that maybe in the 10th edition, instead of waiting for the 11th edition. So things like that, we're really aware of that and we're trying to address that. Then we need to keep in mind that this has to be applicable worldwide, not only in USA, in Canada, in Europe, but also in most of the countries. And then you need to keep in mind that if data collection is too complex, then you will reduce the number and the quality of the data. So you need to some sort of find a balance between the granularity that you want to try to reach with that. And this is some sort of a vision that we might have for the next TNM is basically it will always rely on anatomic extension of the disease, so essential staging, which is a very simple staging system in countries where sometimes they don't have all the information. And then we need to validate what we've done for the 9th edition, which is based on anatomic extent of the disease. But then how can we add new prognostic element on top of that, like pathology, molecular stuff, that will have an impact on clinical management. So that's basically the idea that we want to have in mind when we try to build this next edition. And I was asked to co-chair with Yasushi Yatabe, this new working group, molecular pathology working group, where we want to try to add some of these prognostic elements which are based on histology variables, but also molecular element in the 10th edition. Some consideration when you build something like that, we need to have scientific evidence, strong scientific evidence before incorporating a new element. The example of that is grading in adenocarcinoma. There's a nice paper published by the pathology ISLC group which showed that grading is good and reliable. It has an impact on prognosis. Same thing for STAS. You need to keep in mind that this has to be applicable again. So if centers don't collect STAS, they don't collect grading, then we cannot use that. And also keep in mind for molecular that targeted treatment have an impact on the outcome. So how do you deal with that when you look at the survival and the PFS? Those are a few examples of the elements that we wanted to discuss within the group to see if we felt that that would be something interesting to analyze and then possibly integrate to a new staging system. And this is just an example of work that we've done recently in my lab and that we validate with a cohort from Japan through Yasushi again, where we can show that actually when you integrate prognostic histology-based elements such as LVI, visceral invasion, STAS, you can actually improve how you can predict clinical behavior and evolution in these patients and early unresectable cancer. So that gives you an idea of maybe the future that we have ahead in terms of the 10th edition of the staging. So this, I'm just going to finish with that. Those are the overall objectives that were built by the committee, by the lung cancer staging committee, and basically to assess and incorporate the prognostic impact, what we've developed in the 9th edition, and then to assess the integration of new diagnostic therapeutic advance into prognostic group to try to better discriminate high risk versus low risk patient, and then try to build a repository that could promote future research, AI-based research, and I know that Jonathan has been a big fan of that for the future, and to create and validate the essential TNM for some countries. And this is the objective that every working group have put in place. Primary objective, what are the priorities? Secondary objective, and then more exploratory objective that we want to be trying to collect data, but we know that we won't get this data for all the participating center. So just to conclude, we're now elaborating the 10th edition of the staging system. It has been actively we've been actively working on that over the last year, and it should be ready in 2031. We want to integrate new prognostic element and build prognostic group to better discriminate the clinical evolution of these patients. And I welcome all of you guys that want to participate, that want to collect cases, to reach out to me or to any members of the ISLC staging committee if you want to help us to build a nice data set. Thank you very much for your attention.
Thank you, Philippe.